perspective. And thank you for recording the meeting. My name is Vicky Nassar. I'm going to be the moderator of this webinar. I'm the Executive Officer of Neuroscience and NAMI and Teres Tami Multiple Sclerosis Center at the AUBMC and Fund Coordinator of the Friends of MS at AUBMC too. So I'm going to ask everyone if you have filled out the attendance sheet. If not, the link is available in the chat box. Please do so. I'm going to go through the program of this webinar. We're gonna start with the opening remarks with the IOM Lebanon Head of Office, Mr. Matthew Luciano. We're gonna have to see what's the aim of this webinar. We're going to look a bit about the housekeeping rules of what we can do during the webinar. And then we have a poll survey that you need to go through before we start the talks. So please, meanwhile, if you can proceed by putting your name, introduce yourself through the chat box to know more about you, your background, your country, etc. Please do so. Okay. So now we're going to start with the opening remarks by the IOM Lebanon Head of Office, Mr. Matthew Luciano. Please, the floor is yours.
Thank you very much. Can you hear me?
Yes, we can.
So first I have to apologize because I was in a car for the whole day and got delayed, and now I'm on my way back to Beirut and had to stop in Batroun just for the webinar. So for those of you missing the Lebanese sunset, you have a glimpse of the Lebanese sunset from Batroun as I speak. But listen, it's really a real pleasure to welcome all of you today for this webinar, and especially colleagues joining us from abroad. Your presence here reflects really the strength, the commitment of the Lebanese medical diaspora, and the vision we share for a healthier and more connected future. So IOM, just a few words. So the International Organization for Migration, with the UN agency for migration in Lebanon. We work closely with the Ministry of Health, with local actors, to support national systems to improve access to healthcare and to strengthen the resilience of communities affected by crisis. So our work really in the country spans across primary healthcare, preventative healthcare, emergency preparedness, and emergency response, including cholera response, for instance, mental health, environmental health, and support for all displaced and vulnerable populations, including migrants, including refugees, but also Lebanese host communities. So this webinar in particular is taking place under the framework of a tripartite partnership between the Ministry of Public Health, IOM, and ALMA, the Australian Lebanese Medical Association. And this collaboration was established to create a sustainable channel for engaging Lebanese health professionals abroad. And we work closely with ALMA and with the Health Ministry to establish this international office at the Ministry of Public Health in October 2024 to strengthen cooperation and coordination with the Lebanese diaspora. So today's event is the fourth in a growing series of webinars. And the idea of these webinars is really to promote knowledge exchange and to build bridges between health professionals inside and outside of Lebanon. So I'd like to take this opportunity, really in closing, to thank ALMA, but also the Ministry of Public Health for their continued leadership and for helping with this initiative. So we really look forward to building on this momentum and these type of events to really implement several impactful projects as the outcome of this enhanced partnership between the Health Ministry and between the Lebanese diaspora to improve access, to build capacity, and to ultimately serve the health and the well-being of all communities in Lebanon. So I want to thank you again for being today. I want to apologize again for being on the road, but I really wish you a productive webinar and inspiring discussions. Thank you very much.
Thank you, Mr. Luciano. First, again, I'm going to welcome all this beautiful attendees from everywhere, from Lebanon and outside, from healthcare sector and even as patients. So our webinar's aim is to raise awareness about multiple sclerosis while also exploring latest breakthroughs in treatment, reflecting on local and international approaches. Let me just review with you a bit so far the agenda. We're gonna be talking about lived patient experiences and real-world clinical perspective on recent therapeutic advancement, persistent care challenges, and regional treatment patterns with Dr. Nabil Ayoubi. We're going to also know about the new definitions of MS diagnosis treatment and their applications in Australia and beyond with Dr. Serge Ara. We're going to look at the quick interventions with Mrs. Jane Pousa to know more about unlocking helpful resources in Lebanon. Now, just a bit to know about the housekeeping rules. The microphone, if possible, will be muted for all attendees throughout the session to ensure smooth experience. All your questions can be shared in the Q&A box and left for the Q&A session. During the Q&A, questions from Q&A box will be selected and asked to the speakers. Attendees will be also allowed to unmute their microphones for further interaction at the time. Attendees are kindly requested to remain respectful, stay on topic, and minimize disruptions to the session. And all those participants who will attend the entire session will receive a certificate of attendance. Now, before we start, please take a moment to fill. There is a poll survey that it will gonna be shared on the chat box to you, if possible, so you can do it. So which factor do you think most significantly impacts the quality of life for people living with MS in Lebanon? Access to innovative therapies, availability of multiple sclerosis, multidisciplinary care, regional healthcare infrastructure, or emotional and social support system. I believe you were able to fill the poll. So we're going to start with our first session with Dr. Nabil Ayoubi. Let me give you a beautiful bio about Dr. Ayoubi. Dr. Ayoubi is a full-time researcher, neurologist, and multiple sclerosis specialist at the American University of Beirut, Naame and Teres Tame Multiple Sclerosis Center since 2017. He's an assistant professor of neurology, neurology and multiple sclerosis, and director of the MS Clinical Fellowship Program. He earned his Doctor of Medicine from Los Andes University in Venezuela in 2004 and completed his internal medicine training in 2007. He also obtained a master's in epidemiology and biostatistics from the AUB in 2010. Dr. Ayoubi specialized in neurology, followed by 2 years subspecialty training in neuroimmunology and MS at the MS Center at AUB. In 2018, he was awarded a Fulbright scholarship, during which he worked on the optical coherence tomography, OCT group, at the Johns Hopkins University in the US for 1 year. His research focuses on exploring neuroretina as a window into MS-related neuropathology. Dr. Ayoubi also mentors medical and graduate students as well as residents on research design, and has been providing multidisciplinary MS and neuroimmunology care in Lebanon and the region since 2015. Dr. Ayoubi, the floor is yours. I'm going to stop sharing my screen so you can share yours.
Thank you very much, Vicky. 1 second and we'll have
If you want, in the meantime, we can check the poll results of what the participants have answered on the question to just have a better idea of what do they think about this. Yeah.
Very interesting results. I will tackle them. So I have the presentation and is it showing?
Yes.
Sorry. Not anymore. Maybe right now. So it's seen now, right? Okay. Okay. So it is clear, right? Okay.
Yes, it is, but you can put it as a...
Yeah. So thank you very much, Vicky, for the introduction. Thank you very much for the for this nice initiative, MoPH, ALMA, IOM. It's a pleasure to see some activity going on like this, collaborative between different entities. This is very important, and we're glad this is done right now on time, on good time, which is the Awareness Month for MS, and very important thing to be done in Lebanon right now after all of the turmoil that have been occurring in the past 3 or 4 years. So these are my disclosures, and we thank you again for your support and for the awareness. So I will be just over 15 to 20 minutes tackling from the eyes of our real-world clinical practice, in a nutshell only, because of course we cannot go into details about recent advancements and care challenges and regional treatment patterns. And if we want to just take like pinpoint the main elements that have changed over the past couple of years, one of them is the epidemiology of multiple sclerosis. So, certain areas do not have very good databases or infrastructure, and sometimes you have many countries where you don't have a lot of statistics or knowledge about what's going on. But what is definite for multiple sclerosis is that it has a changing epidemiology. What classically has been considered as a high-risk area above and below the equator, and having all these areas around the equator, our tropical areas, considered as low-risk areas. Nowadays, we know and we understand that these areas have an increasing prevalence. In general, we have a prevalence that ranges between 10 and 100 cases per 100,000 people. And the important thing about this prevalence is that it will increase with time because we have better access to medications, and patients will basically survive and be functional with the disease for longer period of time. The median...
Dr. Ayoubi,
yes.
Excuse me, if you are using your PowerPoint, can you please, move, because it's not moving in PowerPoint slides.
Okay, sorry, yeah.
Okay.
Is it now okay? Like this?
Yeah, it moved. Thank you.
Yeah. Maybe there is a lag or something. So the epidemiology really has changed. So areas that have been considered as low risk are nowadays considered as medium to high prevalence. And this is important in our region because we are one of these areas where we have more multiple sclerosis diagnosed, and we have more incidence, most likely. And the importance of this is because this disease is a disease of the youth. The median age at onset is around 23. It's normally between 20 and 40 years of age, but we are seeing more and more pediatric and later onset MS. And in Lebanon, there was a very nice effort to try to quantify this. And in 2018, we had this study, Dr. Zainuddin and at the MS Center, we had this attempt to lump out what is the exact real world cross-sectional incidence and prevalence of MS, and it was impacting that it was not low. It was around a minimum of 62 cases per 100,000 people, and this is considered medium to high. And the incidence of MS was also not low. Now, what's important is that the risk factors are actually modifying in the over time. So the exposure to tobacco, especially in our region, is an endemic, is a problem. And the vitamin D deficiency has been also shown to play a very, very important role. And apparently, we are here in the Arab countries carrier of some sort of an HLA distinct genetic composition that makes us more prone to have low vitamin D level despite some exposure due to an enzymatic change. So it's very, very prevalent vitamin D deficiency here in the zone in the area. Another important thing is that some other things like adolescence obesity and sedentarism have really kicked into the lifestyle of the region. And this is an endemic also here and an epidemic here in the Arab countries and in Lebanon. And what's important is that all of this kicks in to change or alter the immune networks and cause the immune system to go from a balanced auto-tolerant immune system to an imbalanced pro-inflammatory autoreactive immune system that can kick into the nervous system, identify the myelin, which is the cover of the axons, as foreign and attack them and have this cascade of inflammation and autoimmunity that happens later on. So another important thing that, and I'm just highlighting the advances because Dr. Serge will also talk more in detail about the pathophysiology and other aspects of MS, is that the view of MS or the classic, the paradigms of how we see the disease have changed over the past few years. So the classical view was mostly trying to control the relapses and waiting for the disease to basically become quiescent on the surface. While nowadays we know that a good part of the disease occurs subclinically, in the white matter lesions, in the brain atrophy, and the other type of disease processes that occur below the surface of what you see. So even if a patient is clinically stable, might have been inappropriately controlled or inappropriately managed if there is some ongoing subclinical degeneration and inflammation. And this impacts the possibility of having secondary progressive MS or disability 5, 10, or 15 years into the disease. For this, there have been huge efforts to try to diagnose MS much earlier. And the classical view was usually wait for an attack or a couple of attacks, have dissemination in space and time, meaning having 2 or more areas affected of the central nervous system, at least 2 attacks, exclude an alternative cause of this neurologic syndrome, and basically diagnose MS. And this used to cause a problem because sometimes a patient presents with one of these lesions, but only one attack, or maybe no attacks, or maybe non-specific syndromes. And it posed a significant delay into the diagnosis, because even having all of these white matter lesions, white spots that you see in different parts of the brain or the spinal cord, usually the rule was you had to wait for this to show progression, to show new lesions, to show new attacks, to then diagnose, which can take 3, 4 years, 2 years, 5 years, and then having the access to medications. And nowadays, this have really changed. You just have to rule out the differential, the other potential causes, which are very varied, and this require really a specialist approach to rule out the causes that can mimic MS, and basically go with the more, let's say, more personalized medicine approach. So usually the criteria evolved over time from the 2010 to the 2017 criteria to the recent revision of 2024. And all of this is just trying to say that all the consensus and everything is trying to move into the idea of having diagnosis as early as possible, even at the stage of almost subclinical MS or with minimal symptoms, trying to stop the disease from the beginning. And this really has changed the paradigms of how we diagnose and treat and control this disease. So basically from the first attack with minimal workup, not really depending on many things, we have more advanced MRI, more advanced tests to be done in the CSF, in the fluid, the spinal fluid, in the blood tests, in the retinal optical coherence tomography in the eye. So we have a variety of ways to really feel comfortable diagnosing this disease as early as possible without having to wait for 2 or 3 attacks to have the diagnosis. So having all of these advances is very important because it allows us to diagnose early and control this disease from the beginning and basically stop disability. And but what are the care challenges? So one of the care challenges in this is actually having access to all of these MS diagnostics. So you need, first of all, MS specialists. MS is moving into something similar to, let me say, I compare it to, like, for example, oncology or hematology. It's not anymore the internal medicine that can deal with cancer. It's not even anymore the hematologist, the general oncologist dealing with all types of cancers. Now we have oncologists specializing in certain type of malignancies, in solid tumors, liquid tumors, bone marrow transplant, hematologic malignancies. And this is because of the advancement in personalized biomarkers and the rapid rate of changes in the research and access to different, more complicated medications. And this is happening in MS right now. So we really need more MS specialists to kick in, more people with neurology and neuroimmunology training, a formal neuroimmunology training to kick in and to help taking special care of the patients who have the difficult cases, the pediatric onset cases, the late onset cases, the advanced cases, the severe cases. And we're working on this, and now we will see how we are trying to basically collaborate with our colleagues everywhere and trying to improve the access to MS specialists in this way. Another very important challenge is the access to proper MRI. So MRI can be seen like something very banal or distributed everywhere, but the appropriate 1.53 Tesla MRI, the appropriate MRI techniques are not available everywhere. This is a challenge. And this is really because of the financial issues with centers taking, acquiring appropriate MRI. Optical coherence tomography is mostly in MS centers, specialized care. So also there is a limitation in the access to this. And all of this is really related to having, again, MS diagnostic, MS special teams, MS specialists, and multidisciplinary care. Another issue is that we have a change in treatment paradigms. So the conventional phenotype of having phases of MS and then having a progressive phase later on have changed into something that is more overlapping. And this poses a real challenge because we need to use the more aggressive medication, the more effective medications from the beginning and not later on in the disease course. And this has really been proven by myriads of trials. So the issue is that now we have different therapeutic goals. So it's not anymore just reduce relapses. Now it's improving relapses, controlling relapses, controlling new lesion development, but also controlling quality of life, disability, and the possibility of later on having subclinical disease activity. And this is very, of course, intricate and requires a multidisciplinary approach by a huge team, at least taking care of these aspects that I mentioned here. Everything going from fatigue, cognition, bowel bladder, partnership, sexuality, pain, vision, mobility, everything. And this is doable. This is something that's done at the MS Center, and this is something that we need more, basically, to take some extra time with the patient to be able to tackle all of these things and control the disease. Now, as for the treatment access, which is another thing that is a challenge, we had this old school, basically I call it old school or classical first line, second line, third line, fourth line escalation type of treatment. And this has been shown that we should not do this. Having to basically encase the patients in a type of treatment and then wait for them to fail to escalate to a different treatment which might have been more effective if used before, this is definitely not a good approach. And this has been changed, and the ministry, despite all of this, the difficulty has really been very cooperative with us within the limitations of them to really have an idea, a view of what medication should be accessible for the patients and how to approve them. Now, of course, there are myriad of medications. It's very difficult for everyone to have a very clear guideline. That's why we need to basically understand that the medications that are being approved and are getting in are going to be difficult to manage, and we need really the specialized committee of physicians with neuroimmunology expertise and training to decide on these guidelines, as it is right away down here in Lebanon and in the Arab region usually done. So last few slides is just to say that the main, if we take care of all of this, if we take care of the access to medications, the ability to control disease early on, and the multidisciplinary approach that can be tackled to control this disease early on in these young people, to maintain a good health-related quality of life, to avoid disability, and to keep a good psychosocial and cognitive and independence and everything related to autonomy and independence. Let me say that this is really the way, or really an attainable and achievable target that we are basically we aim to achieve in each patient through personalized medicine. So what we want is our MS patients always to be in to achieve good well-being. And there has been a lot of studies about what impacts the well-being of in MS. It's not only the subtype of MS or the MRI disease burden. The strongest predictors are actually things that need to be tackled beside the issue of which treatment is the patient taking. Depression, demoralization, cognitive impairment, autonomy, support, pain. So this is what a multidimensional aspect, and this makes MS very intricate in the management. And this is why we need the MS patients should be treated at specialized and multidisciplinary holistic MS centers to be able to take care of all of these things, because these are young patients usually. And what we need right now, despite the war, despite all of the problems that we had here in the area, is to keep working on having appropriate autonomy and control of the disease, communication, social preservation, and disease rehabilitation. Now, what is happening in the region with respect to medications? I was very happy to see in the poll that many people thought that around 30% had the answer about the issue of psychosocial and psychological stigma and as a limitation or a barrier to MS in the region. And that's really true, because as for medications, they answered like 19% access to another medications. It's true. It's not actually the lack of medication. It is a problem not having all the medications, but that's not the main issue. We have appropriate coverage with the basic medications to have a cover of different spectrums and to cover the escalation patterns for different patients according to disease duration. But of course, right now, we have a lot of problems with budgeting through the social services and the Ministry of Health and National Security Fund, etc., because these medications, until 2019, all of these medications were covered to the majority of the population. And then after the crisis, we had to stick to only a couple of off-label and then a couple of mild efficacy medication. So we were getting out of a very, very severe crisis, but we survived it. So let me tell that in the whole MENA region and the Arab countries, there are barriers to access multiple sclerosis DMTs. And it is really somehow related to the level of income of the country, but to a greater extent, and you can see this with more detail later on, it's pretty much related to the cost of the treatment and the health professionals. And again, this kicks on the red part, the health professionals with specialist knowledge to treat MS and administer the very advanced DMT. So this is very important. Here I'm showing just that in general, in every one of these countries, at least a number of treatments is available. It's a complicated graph, but at least there is in every country a piece of red, orange, and at least a gray one, which is high, moderate, and low efficacy. At least there are 3 types of treatments: mild, moderate, and high efficacy treatments in each part of the world. Of course, not all the treatments are available everywhere, and we have, of course, very bad exceptions. For example, in Sudan, they are left with only few medications off-label, and this is a problem there. Now, what do we do to overcome all of these barriers? What are we doing and how can we help? Well, we have the MS Center at AUBMC, the NAMA and Terestame MS Center, and we collaborate with our colleagues all around Lebanon and in the region. We provide specialized MS care, and we have a lot of patients in Lebanon. So we really have to collaborate with a lot of patients, a lot of physicians and centers around in the region, because we have to have this network going on. And we need to provide training and help other physicians get access, and patients get access to multidisciplinary care. We have specialized neurology and neurology training, myself and Dr. Samir Khouri. We have a specialized nursing with specialized training in MS, infusion therapy, and of course, multidimensional treatment that we talked about. What's very important is that this disease, as is being treated, we have research ongoing. I tell patients, you're being treated along with the edge of research, and this is why there's no other way but to have research and MS care integrated and all together at MS centers to be able to provide opportune treatment before patients actually lose the opportunity to have access to specialized biomarkers or MS care. We have this awareness campaign booth and campaign with partnership with the Ministry of Public Health and Friends of MS. And of course, all of these years, and I was basically asked by the ministry to show what have been done, how did we navigate this crisis between 2019 to now. This has been very difficult, but yes, there has been a lot of work by the MS Center team, by the Friends of MS, by Ms. Vicky, by the MoPH, and contacting NGOs, international donations, price adjustments, all sorts of problems have gotten solved and tackled by this beautiful team. And of course, collaboration with MoPH, local NGOs, media agencies, and everything. And from my part, what I want to say is that, and again, I want to reinforce this need, is that a formal 2 years MS clinical fellowship subspecialty training is very important for neurologists to be done abroad, here, everywhere. There is the MENACTRIMS, there is the ECTRIMS sponsorships, there is in the States very good programs. So, and this is because of the amount of knowledge that is kicking out from clinical trials, from observational studies, and we are leaders in this also, and collaborating with our colleagues here in Lebanon and abroad, and MS biomarkers, OCT, etc. So Let me tell you finally that, yes, this is a very complicated, but at the same time, a very hopeful specialty. We are very cheerful about being able to help all these kids and ladies and gentlemen and even elderly who get MS diagnosed. We are very positive when we diagnose them. We know that we can control their disease. There is no more this sad view about MS. We can diagnose and treat early, and basically we can monitor, escalate on time, and basically support and improve the quality of life. So that should be the objective for everyone. Healthcare workers, thank you very much for attending this very nice conference. Thank you.
Thank you, Dr. Ayubi, for this rich presentation. Really, you were able to include and shed light about all the most important approaches in MS treatment, access to care, the multidimensional, multidisciplinary care that is needed for the MS and at any center of excellence that cares for and caters for MS. And personally, I would like to thank you for all the extra miles efforts that you are now doing to help and support the patients, either by their management or by the needs that they are facing, especially during the past 6 years that we were facing in the period that we faced during the disasters in the economy, and the access to treatment and availability of the medications, and even the financial problem. Now, I would like to reiterate for all the attendees who are with us, who are interested to ask any questions, please jot down your questions on the chat box. We will review them and we will share them with the speakers later on. Now we will go with Dr. Serge Jara to talk more about new definitions of MS, diagnosis, treatment, and their application in Australia and beyond. Let me just give you a small yet important biography of Dr. Jara. Dr. Jara graduated from the American University of Beirut with a BA in psychology and completed his medical studies with an MBBS from the University of Sydney in 2015. He is a fellow of the Royal Australasian College of Physicians and is currently completing a fellowship in mitochondrial disease. He also serves as a visiting medical officer attending at Northern Beaches Hospital. He has previously completed a fellowship in motor neuron disease. His experience in neuroimmunology stems from working alongside experts in the field, and he is expected to complete a master's by research at the University of Sydney on neuroimmunology of uveitis by the end of this June. Outside this medical beautiful career, he enjoys learning languages, following the Lebanese basketball team in international tournaments, and listening to jazz. Who doesn't follow the Lebanese basketball team? We all do. The floor is yours, Dr. Jara.
Thank you. Thank you, everybody. Yeah, there's very little sometimes to be looking forward to, but when you watch the Lebanese team, it's just sort of a microcosm of what we can do as people when we're united, and it just gives me a lot of hope. Plus, I like basketball. So thank you, everybody, for attending. Excuse me if I make any phonemic or paraphrasias, if I make any mistakes. It's a bit late here in Sydney. My name is Dr. Serge Jara. I'll be talking. My talk is going to be a bit mixed from a few topics. I just thought these would be important, looking at how the diagnosis changed. And I did a bit of sort of a pivot in my thinking to see how does the new criteria, the McDonald's criteria, affect things, and just a few, I guess, tips about how to look into it. So thank you, everybody, for coming. I'll just share my slides. All right. Are we on board? Let me double check something. Okay. Is it in presenter mode? Great. All right. So no conflicts of interest and no financial or pecuniary interests, including any investing in pharma companies. So today's talk, I was hoping to first thank you, Dr. Ayubi. This is a great system, and what we need to start thinking of as, and I want to echo Dr. Ayubi, is the fact that we want to be able at the moment, with optimal care in developed countries, we have the ability to have a same life expectancy as a person without MS. So we can reach the 70, 75 years old, which was unheard of back in even about 10 years or 15 years ago. So to be able to apply that means that it is primarily an access issue, and it's an access to both services, but also to the expertise of people around. So I wanted to see what is happening in the literature and try to reflect that in how one could be able to help in that situation. So my outline will be mostly about a brief overview of the diagnosis and the effects that happen as a result of that, advances in therapy, and looking into low-cost, higher efficacy therapies, and thinking about equitable MS care that can be applied to anybody, or hopefully be able to apply to everybody. So the definition of multiple sclerosis in general is that it's a neuroinflammatory condition that affects primarily white matter disease. That's a classical definition. But now we know that there's a lot of other areas that are involved in the central nervous system. It's both in the brain or the spinal cord. The definition includes usually what is called a separation in space and time, which means that they should happen in different areas in the brain or central nervous system, and then time. Again, that's a classical definition, and we'll go back to that. And the same study that Dr. Ayoubi has quoted has an incidence of 8.36 in 100,000, which means it's a medium incidence disease in Lebanon, and that's important, which means that about 40 times 8 or 50 times 8 is about 200 people every year get diagnosed with MS on top of whatever is already happening with the prevalence. In Australia, it's an extremely high incidence disease because of being away from the equator in terms of the longitude lines, as well as the HLA predisposition. And something that's interesting that Dr. Ayoubi mentioned was the fact that the vitamin D deficiency, despite having access to ample sun, and it's actually interesting. I always thought about the reason of why is that the case, but the HLA-B association could explain that, and that's really interesting. And the incidence is increasing in both countries. I think there's a few putative theories, either the rise of infection and including EBV, which is a new theory, or things that were looked at in females is the increase of covert stress, which is not expressed, which can somehow increase the risk of autoimmunity. So it's something that we need to be able to tackle as a result. So the previous criteria in 2017, which sort of is mostly still in practice, is that you need to have two relapses. If you have two relapses that are happen either in radiologically, where you see the development of new lesions on MRI FLAIR, or two distinct episodes with an associated clinical syndrome, which is explanatory, would give you the diagnosis. If you have two more relapses, but then you need to get imaging evidence, then you get the diagnosis. And that would be dissociation in time. If you have one relapse, but you see that there was evidence previously of previous lesions, then you need to sort of further confirm that. So you need to repeat the MRI in a few months, or you need oligoclonal bands. So that puts people who already have morbidity in a situation where they have to wait without treatment, and that might be a bit difficult for patients and carers to swallow as a result of the fact that you want to be able to help patients and jump in if you have the suspicion that that's the case, that MS is the diagnosis. And then if you have one attack or relapse with objective evidence of a lesion, you need, again, to wait. And then if you had insidious neurological progression of suggestive of MS, you need to keep following up for about a year, and you need to look at the MRI lesion. So this was the previous criteria. The criteria were based on clinical and radiological classic syndromes. So the first part is the periventricular lesions. So Dr. Ayubi had a slide on these. Infratentorial, so lesions in the cerebellum or in the brainstem. Spinal cord lesions, which affect the white matter, and cortical and juxtacortical lesions. So these are the sort of new issue. And then the classic clinical syndrome is that of something that affects patients in a way that we know previously patients with MS have had. So eye symptoms and double vision and issues with the optic nerve. Optic neuritis is obviously in recognized side effect. The spinal cord issues can give you spasticity, can give you bladder issues and gait issues. And in the brain, you can get gait issues, but you can also get new onset unexplained fatigue or depression. So the syndrome is pretty big, but putting it together gives somebody a sort of answer. The 2024 update is mostly in ECTRIMS, so that's why there's not much papers that involve that. But basically, the idea is that with all these syndromes that we looked at, the optic nerve involvement has become a radiologically distinct entity. And the reason why this was a bit controversial, and I'll get to that, is there were some syndromes such as the NMOSD related inflammation that responds to different set of medications was usually one of the classical syndromes was isolated in the eye. However, now we recognize that there are different distributions, and I'll talk about that a bit later. Previously, oligoclonal bands, which are basically inflammation that tells us that, a marker that tells us there's inflammation in the central nervous system. But now the addition was that of a CSF kappa-free light chain, which is basically the antibody molecule. We are able to measure the amount and the presence of a kappa-free light chain, which I'll look into as well later, and as a marker of severity. And there was 2 new imaging markers also that were looked at, which are the central vein sign, which was recognized but not felt to be diagnostic, and the paramagnetic rim lesion. So these are all basically, that's part of the update. But the second part of the update is the fact that if you have lesions that are more than 5 or 6 in one radiologically or clinically isolated syndrome, you can actually say, okay, I'm safe enough to say that this is an MS diagnosis. And the idea is twofold. First up, it's helping us say, okay, well, we can jump to treatment if we are fairly certain based on the information that we have and the new research that's suggested that this is a likely picture. And then the second part is the fact that it also helps potentially look into research at people who might have lesions but are otherwise asymptomatic or oligosymptomatic, low symptoms. So yeah, like I mentioned, the clarity on the radiologically isolated syndrome. So CSF serum-free light chain is basically what your body secretes as a result of inflammation. There is usually T cell or B cell based, and now we recognize that MS is a disease of both cells, as in contrast to classically thinking it's a B cell disease. And basically, these can be measured to tell us the amount of inflammation. It's been validated in a few things, so it is a marker. It's more sensitive in some ways than oligoclonal bands. But also the important part of it is that it helps quantify the situation in patients who have had an acute relapse and whether or not it's a severe or not. But obviously, there's also the clinical side of it, so it's important. So it's also cheaper to test than oligoclonal bands, at least in Australia. So looking at the new signs, the radiological signs, this is an MRI with the susceptibility weighted imaging. So everything that's black has usually have metals with electrons around it, and everything around it basically tells you that everything that is sort of black is telling us that there's either blood because there's iron there, or other heavy metal products. So in this area, you can see that there's an area of hyper intensity around a circle in the middle, and that's a paramagnetic rim sign. It's usually felt to be due to indolent MS, which is important because now we can include that in patients whose symptoms are slowly progressing, and there's a vessel in the middle, and this is the likely target of the TKIs, the tyrosine kinase inhibitors, which is felt to be the new frontier, but we'll also discuss that later. And then there's the central vein sign. So this is the same image. You're not seeing double. And basically, you could see how there's a vascular component to this, which is the pathophysiology is not fully clear, but it's felt to be that there's a neovascularization to that lesion. And that there are certain radiological criteria to that. So it has to be, the vessel itself has to be less than 2 millimeters, because then it will be either part of a major vessel or different. It runs partially or fully through the lesion, so it needs to go into the lesion. It needs to be positioned centrally, and it needs to be visualized on 2 perpendicular images, so axial coronal or axial sagittal. And it's usually a thin dot through the middle. So looking at the optic nerve distributions, this is a work done by my colleague. There's a suggestion that what the pattern of inflammation is in optic neuritis can clue us into what the diagnosis may be. And why is that important? Because the treatment for MS will be slightly different in the subacute phase than aquaporin for MOG-related optic neuritis. So in MOG-related optic neuritis, you get higher risk of optic disc swelling and bilateral optic neuritis. In aquaporin 4, it's usually longitudinally extensive and patchy, and it crosses the optic chiasm, so people can have visual field deficits as well. And the MS optic neuritis is usually focal and short segment. So looking at that in imaging becomes very important. So this is which brings us to the next question about imaging and all. So there's an impact of this criteria on practicing clinicians and on the patients themselves. We need more resources. So Dr. Ayubi mentioned that not only do you need any MRI, you need MRIs that are specified, that can give you good images of the optic nerve, that can enhance adequately to gadolinium tracers, and can have good gadolinium enhancement. And you need also radiologists and radiographers that are able to give you the sequences that you're looking for in order to be able to answer the question that you're trying to ask. And then but then in total, because of the radiologically isolated syndrome, this might be a benefit that you might be able to make the diagnosis based on the radiologically isolated syndrome. So you might need less imaging. And then also compared to that, given the high efficacy treatment, obviously there might be subclinical progression. You might have less frequency for imaging. So that could go one way or the other. I think the new McDonald's criteria is very clinically oriented, and there's a lot of research in that space, but it also can be used in one way or another to optimize access to care, and to think about MRI for high-risk individuals versus normal risk individuals. And the new non-MRI markers, such as the blood markers and the CSF markers, can be very important. And I mentioned already serum-free light chains. So the principles of management in the big groups of the diseases, I just wanted to go quickly through the medications, is to decrease relapses, to delay progressions, to manage the symptoms, and improve the quality of life. And the new holy grail in treatment of MS is going to be reversal or complete stoppage of inflammation, which is in the works at the moment. And then obviously the therapy is either in acute management, in disease-modifying therapies, and in symptomatic treatments. I won't go into the symptomatic treatments a lot today in terms of pharmacological therapy, but I'll look into acute and disease-modifying therapies. So in acute setting, in exacerbation and an acute worsening, high-dose corticosteroids for a short amount of time, so IV methylprednisolone or oral, it shortens the duration of the relapse. And then IVIG or plasma exchange. In Australia, we're lucky to have a blood donor public program that gives us access to IVIG. So I must say IVIG is probably a bit overused, but high-dose corticosteroids are equivalent in head-to-head studies, and this is usually used in steroid refractory cases. So these are the sort of two modalities, and then sort of monitoring how patients go. Obviously, imaging then is important because we want to see if there's any new lesions that we can see or progression of old lesions. The low to medium efficacy is what we define now as basically a 30 to 50% decrease in exacerbations in an annualized rate. So every year, instead of having, let's say, that's an unrealistic number, but let's say if you had 5, now you have 3 or 4. And these include the interferon beta, which is the injectable, and glutathione acetate, which is Copaxone, which usually give you slight side effects of flu-like illness. There was previously reports of depression, and then the orals, which include dimethyl fumarate, which has recently been revamped in a new way, but it's also cost-effective. Teriflunomide, fingolimod, and ozanimod. I'll talk about fingolimod later because some people consider it also medium efficacy. The medium efficacy includes fingolimod, which is an S1P receptor modulator, which is decreases the annual relapse of about 54% based on the FREEDOMS trial, and decreases brain atrophy by 30%. So the chronic inflammation can cause brain atrophy, particularly actually in the gray matter. And the cost is in the US is about $10,000 a month, but there are generic versions which are sort of popping into the market now, given the medication is 15 years. There's a few side effects for it. So there's bradykinesia, there's slow heart rate, there's headache, and there's hypertension and high liver function tests. And some people can have HSV encephalitis, and some people can have macular edema. So it's very important to keep looking into the back of the eye and examining the patient's situation. Natalizumab is an alpha-4 integrin inhibitor. So basically what it does is it's a monoclonal antibody that stops the cells from trafficking and going out of the vessels into the central nervous system to be able to exert their immunologic effect. And the relapses are getting there. So we're getting to 68% versus placebo. And the disability progression is much slower at 42% less in 2 years. And the problem is that its cost is high, and then there's the risk of PML, which is an infection related to JC virus, which is usually circulating, and most people have it. So the recommendations usually is to do antibody testing every 6 months. Some people do less testing once it's sort of stable, but also check the status beforehand, because if you haven't had the infection, it means you haven't mounted an immune response. That's important to also look at. And then cladribine, which is a purine analog. So your DNA is pyrimidine and purine, and you need these DNA building blocks in order to help rapidly dividing cells. Basically, the efficacy of that is it's about 58% in the Clarity trial, and it's a 2-year oral course with durable effect. So basically, you take 10 to 20 tablets based on your weight and age, which is, despite the cost, is sort of compressed into the few tablets. These get taken, and then you just monitor for the side effects. So the rest of the workup is to look to make sure that there's no side effects that are bad. You see some lymphopenia because you're stopping the white cells from dividing, and you just need to sort of make sure that the lymphopenia is not too bad, and also because the white cells, the T cells, look for and monitor for cancers. You need to make sure that you do a malignancy risk check, which is also resource intensive. So, I mean, the benefits of this is short course. You need to make sure that you don't give it during pregnancy as well. So you do a pregnancy test. And now there's the new era of CD20 and B cell therapies. So these are therapies that tackle the B cell, and they're all felt to be highly active. They're given via infusions, which lends them good to trials and being able to mention things, but also the fact that there's a limited amount of doses that is needed. In Australia, ofatumumab has recently been approved by the government, so it's highly subsidized. Ocrelizumab is also used, and head-to-head, if you use one, you can use the other. So it's very important. And The other thing about ofatumumab is that it's subcutaneous, so patients can give it to themselves and they don't necessarily have to come to clinic. What people think of as in these therapies is that they're high reward, but there is a small but high risk in this situation of autoimmune disorders such as immune thrombocytopenic purpura or autoimmune thyroiditis. So it's very important to make sure that you monitor for these complications as well. So now I just wanted to pivot a bit more. So this is the sort of cutting edge. The Bruton kinase receptors helps the B cells differentiate and affect their go to their effector cells to affect the myelin in the central nervous system in the brain and spinal cord. And blocking that basically helps slow down neuroinflammation. And the feeling is that the cells themselves then start to repair as a result of the of that effector situation not happening anymore. And the hope is that by blocking the Bruton tyrosine kinase receptors, that there will be potential remyelination as well. So it's been touted as a very positive treatment, and it's been looked at a few studies. I'm just going to go through a NEJM study that was used. So there's the trial was in 2004 in NEJM in New English Journal of Medicine. They basically considered it a positive result if the patient's expanded disability status scale. So this is what can you do versus no disability at all. You can run marathons. If you had an improvement by 1 point in that scale that was positive versus 0.5 if it was a lower scale, because to adjust for small changes in patients who are less disabled. And basically they looked at one of these medications called tolebrutinib, and the disability progression scale was decreased by 8% in about 1,100 patients compared to placebo. This was a positive result, but the problem is that people still had progression of their disease, which was not the expected situation. So there's further studying that needs to be happening into that. And there was a study that looked at comparing tolebrutinib recently to teriflunomide, and it yielded equal results. So the idea is that we want to be able to have a newer and more efficacious therapy, and they're still finding their space. So watch this space. There'll be research in the next few years that pertains to that. And then in Australia as well, once St. Vincent's Hospital does stem cell transplant for aggressive MS. And it's interesting that you mentioned the sort of oncology or hematology model, because there's a subset of neuroimmunologists that are become basically good hematologists as a result of that. And that's usually looked at for patients with extreme cases where there is aggressive disease that is resistant to oral therapy, and you need to sort of jump in early because, again, obviously that's a very resource intensive and risky. But also the therapies have been established in different diseases, and therefore the feeling is that the management will be already well known as a result of that. So I wanted to look a bit into non-pharmacological interventions that don't necessarily need tablets.
Excuse me,
or
Dr. Jara. We still have
Yes.
5 minutes, please.
No worries, I'll be done in 5 minutes. Thank you.
Great.
So one of the things has always been looked at is exercise programs, but the reason why this is important is that outside of the actual exercise itself, it needs to be tailored to the patient themselves, because MS can have a lot of different manifestations. So if the manifestations are in the lower limbs, you look into the lower limbs, and this is a meta-analysis that looks into the basic benefit. There is a sort of 2 standard deviation benefit towards the exercise and modification space and things. Cognitive behavioral therapy, it relates to the depression symptoms and the psychiatric symptoms, psychological and psychiatric symptoms that happen in MS, but can also be helpful for understanding the disease. The idea is that they need to be short, guided, and help set the patient up for their ways of thinking. And the positives is that they can be done remotely, and they can be translated, as a lot of these questionnaires and therapies have been looked at in the Arab and Middle East countries. And finally, the one thing I wanted to see about the Lebanese context, we've been through so much. We've been through wars. We've been through an economic decline, which has affected a lot of us, even me as a recent migrant. I look into that, and it's really hard. But one of the things that is protective compared to countries like Australia, and maybe that's a bit of an opinion, is the presence of a social support. And this is a study from a few years ago that looks into the symptoms and the severity of symptoms in patients who have one confidant, one person that they can share their problems and issues with. So having your social support around your family, your friends, is always very helpful to help increase your survival. And I think it's very important that we foster that as part of our culture as well. And I did not know that the other speaker is part of the Tommy MS Center at AUB, but I encourage people, I mean, I don't know what the referral situation is like, but I encourage people to be part of the trials, even if they're being cared for by another clinician. I think it's very important to get the research on, but also that will improve access to patients to high efficacy medications, and we could get to know how it works in the Lebanese context and for our patients in Lebanon. And I would like to also say that MS Base, which is the international the international database. Yes, sorry. We should probably get more clinicians involved in it, and I'm pretty sure Tommy Medical Center is also part of that. But basically, looking into research trials can improve access to people, because then if the therapies are efficacious, then the patients can benefit from that as well. Thank you so much.
Thank you, Dr. Jara. Really appreciating the talk, especially that you highlighted all the steps and the very close approach that is done by specialists to be able to diagnose and treat MS. And this is really focuses on that the treatment of MS, it should be done by a specialist who has been through a lot of training, research to be able to take care of these patients. Dr. Nabil, if you have any say about this, please do. If not, please, anyone who has a question, jot it down in the chat box so we can share it again. So now we go for a quick intervention by Mrs. Jane Kousa. A small introduction about Mrs. Jane. She is the president and founder of ALICEP, Association Libanaise contre la Sclérose en Plaques, a Lebanese NGO focused on awareness and for support for multiple sclerosis, which was founded in 2012. She has been actively involved in raising awareness about multiple sclerosis and advocating for patients' rights in Lebanon. Her work includes organizing campaigns and events to highlight the challenges faced by MS patients and to promote understanding and support for them. The floor is yours, Mrs. Jane.
Thank you, Mrs. Vicky. Good evening, everyone. Thank you for making me a part of this awareness campaign in Lebanon, because we are really in need of that. It's an honor to speak with you today in my capacity as a president of ALICEP, the Lebanese Association for Multiple Sclerosis. ALICEP was founded in 2012 with a simple but powerful goal: to bring together and support people affected by multiple sclerosis across all Lebanon. What began as a modest effort serving just 400 patients has grown into a national community of over 1,500 registered patients representing voices from all the regions of Lebanon. We're proud to become one of the first and the largest associations in Lebanon dedicated exclusively to MS. But more importantly, we're proud of the trust we have earned from patients and families. ALICEP is not just an organization, it's a lifeline. At the core of ALICEP's work lies deeply humanitarian mission. We are committed to easing the burden of this disease by offering moral and psychological as well as financial support. Our work touches every aspect of a patient's life, because MS is not just a neurological condition. It's a life-altering journey that affects families, careers, mental health, and daily dignity. In the past, many people with MS in Lebanon lived in the shadows. There was a lack of awareness, a lack of access to care, and a painful silence around their needs. ALICEP emerged as a beacon to shed light on this disease, to break that silence, and to give patients the attention and care they deserve. Our moral support begins with awareness. We organize frequent information sessions, public campaigns, and expert-led conferences. They are open to patients, families, and the broader public. Our goal is to educate, inform, and empower because knowledge is the first step toward acceptance and control. We have brought MS to the forefront of medical dialogue in Lebanon. Through our annual participation in World MS Day, we amplify patient voices, celebrate resilience, and push for change. But awareness alone is not enough. The emotional toll of MS is immense. That's why we prioritize psychological support through counseling programs, peer support groups, and wellness sessions. We want every patient to know that he is not alone. And of course, living with MS in Lebanon is uniquely challenging. Over the past 6 years, our country has been hit by a perfect storm of crisis, economic collapse, healthcare shortages, and political instability. For MS patients, this has meant interrupted access to critical medications, unaffordable treatments, and delays in diagnosis and follow-up care. At times, it meant having to choose between putting food on the table and securing life-sustaining treatment. LeMSIC stepped up during this period. We provided, as much as we can, of course, direct financial support where we could, and we worked tirelessly to secure donations both locally and internationally. Through advocacy and outreach, we partnered with pharmaceutical companies and government bodies to advocate for the continuity of care and access to treatment for all MS patients, regardless of income or background. We also advocated for MS patients' rights at every possible level. We believe it's not enough to treat the disease. We must also fight the systemic barriers that prevent MS patients from living full, empowered lives. Beyond support, LeMSIC is about community. We bring together patients and caregivers, doctors, advocates, and volunteers. We create safe spaces where stories are shared, fears are voiced, and courage is built. We've also worked hard to destigmatize MS. This disease does not define a person, and it certainly does not limit their ability to contribute, to thrive, or to dream. Through campaigns, media, and collaboration with public figures, we strive to change the narrative around MS from one of limitation to one of possibility. Looking ahead, but we know there is still so much more to do. As we look ahead, LeMSIC is committed to expanding mental health resources for patients and caregivers, strengthening our advocacy for universal access to MS medication and care, building research collaborations to better understand the unique needs of Lebanese MS patients, developing home care and rehabilitation support, especially in underserved and remote areas, and most importantly, continuing to be a voice for every person who feels forgotten, unseen, or unheard. All of this is not just a vision, it's our dream, a dream born from the stories, the strength, and the suffering of our patients. But this dream is fragile because our country is injured. Lebanon has been deeply wounded by economic collapse, political instability, and healthcare, as I said before, and system breakdowns, of course. We cannot achieve these goals alone. To turn this dream into reality, we urgently need international financial support, strategic partnerships, and solidarity from the global MS community and humanitarian organizations. Together, we can rebuild not just systems, but hope. Let me end with this. Multiple sclerosis is a difficult road, but it's a road that does not need to be walked alone. At LeMSIC, we walk it together with strength, with resilience, and with fierce belief in the human spirit. We invite all of you, policymakers, healthcare providers, allies, and supporters to stand with us, partner with us, and walk with us toward a future where MS care in Lebanon is not a privilege, but a right. Thank you.
Thank you, Mrs. Musa. I would like also to emphasize the needs of collaborative work, and I would like also to shed light on other NGOs and volunteer groups who had tremendous also input in their work during the past 6-7 years. Among the Friends of MS at AUBMC, who's been established since February 2012, Their main focus, they are also a joint people who joined the MS Center, نعمة تريس طعمي at UBMC, to support patients in fundraising, to support also patients with their awareness campaign and the research at the center. For the past 6 years, they were, as Dr. Ayoubi was talking, they worked jointly not only with the MS Center, but also with another NGO that is ALICEP, Amis Libanais Sclerosis en Plaques, that is a Lebanese NGO founded by and for people living with multiple sclerosis, dedicated to improving their quality of life through advocacy, awareness, and support. They usually work during the crisis by providing first the database for the MoPH, registering the patient through the HID and the AMAN files, and also distributing medication through the MS Center and also with other partnerships. Not to forget also that this highlight of having multi-level and multi-sector support from different identities is very needed to help and support the MS patient, and maybe also to join the effort to raise awareness and to raise the voice that there is a need for multi problems to tackle and look up to them, especially that Dr. Jara just mentioned, the list of medication that we lack a lot in our country nowadays. You made us look back to the pre-2019, Dr. Jara, and Dr. Ayoubi also with the whole multi-dimensional and multidisciplinary care that we need. Please, we have questions the first question that we will take is by Ms. Ibtisam Badran. What is the role of AI in diagnosing MS? I give the floor to both of you.
Can I answer this?
Oh, yeah.
Yes,
one of my not supervisors, but one of the experts in MS in Australia, Professor Michael Barnett, has actually working on this relentlessly. So basically, he is looking at putting a database of patients that we already know have MS or have had progressions, and using this as a basis for AI for future to help with situations in which, you know, the lesion has grown by 1 millimeter and we don't know if it's because of the image acquisition versus versus it's actually progression. And they're using that to also target the therapies to see which therapies work for aggressive forms better versus for indolent forms. So there is a lot of work into that. And I think it's also going to be helpful to match cost to patient care as well by putting a certain level of inputs as well.
Dr. Ayoubi, do you have an input about that?
That's great. Well, this is an area that it will be booming. The use of AI in every aspect, be it diagnosis, treatment, or monitoring. And I will add that as an expert in retinal optical coherence tomography, I think the retinal OCT in MS and the MS centers, as it is so easy to access and non-invasive and not time-consuming and easy to do, with all its limitation, I think that the ability of the new machines to do in spectral domain to export images, and this is going to be mind-blowing. There are already a lot of groups working on AI in retinal OCT, and we do this also, and this is going to be very informative. Basically, whatever happens in the brain on a brain MRI will be shown on a retinal OCT as a micro sample of the brain, so as a window into the brain. So yeah, a lot of things are going to go on regarding AI and the sources of images. So we're looking forward.
Okay.
I know you want to take a question, but I just want to make a comment that AI gets used a lot in ways that are not very useful, and it has a burden in the environment and society. So, you know, when we use it for clinical treatment of patients and improving patients' outcomes, that's much better use, in my opinion, and that's what we were trying to say. Sorry to interrupt, Vicky. I'm really sorry.
No worries, no worries. There is another question. For newly diagnosed, highly active MS, which treatments options are the most cost-effective?
Yeah, so we have the Lebanese and the Australian way. What do you think?
Yeah.
Okay,
Um,
let me say, by the guidelines, I think Dr. Serge will now respond, but in our, let's say, 5 years of stagnation, war, displacement, lack of social security, we had to go for rituximab. Although we know that we are using it for a brief period of time, we are begging now the ministry, and hopefully they are responding now that we are picking up out of the crisis, that we are going to shift back to FDA-approved medications on the go after a few cycles of rituximab, because there has been an overuse of rituximab and the risks of immunosuppression, oncogenic risk, and all of that. But yes, that's what we were able to use for a while. We also have the, of course, if it's very highly active and there is no time for things to kick in, we still use Tysabri, we still use natalizumab, we still use if it's not very, very highly active right now, it has been like active over the past year or so, we can use cladribine. It's very cost effective. And of course, Ocrevus for those who have the coverage, especially private coverage, to be able to cover for it. So that's what we have been doing here, and ofatumumab recently kicked in. So I don't know, in Australia, I think it's clearer, right?
Yeah, so MS, we're sort of lucky here in Australia because all medications in MS are subsidized. So all the ones that are approved by the PBS, which is our FDA sort of equivalent. So you can reach for the one that you think is the most appropriate, and that helps also lends itself for good research. We tend to go for the ocrelizumab or ofatumumab if things are really bad. Tysabri, if the patient's JC serology is positive, so they already have mounted an immunity, we tend to be more likely to use it, although that's sort of moving out of fashion as well. And for some cases where you treat for about a month or so, and the patient is not improving, it's still progressing, like I mentioned, we're doing the stem cell transplant in some centers. It's very specialized, and there's about 1 or 2 per state. So, and a state in Australia is huge. So, but I guess that's the sort of situation. Now, ofatumumab is gaining a lot of traction because of the fact that it's subcut. So once you don't need to come to a place to do an infusion. So it's becoming more and more accessible given that it's good head-to-head data. So this is for sort of aggressive acute. Cladribine, usually if there's concerns about, potentially pregnancy or anything like that, we tend to move away, but there's a few people that reach for it, some clinicians. So in some ways we do have all the options, but yeah, I do mirror with the limitation of access, I do mirror Dr. Ayubi's approach to that.
Yeah, let me say that for the attendee who asked, we also do, like Dr. Khoury has a couple of BMT patients per year for the very highly aggressive or the rapidly progressive. This is very important, that even the protocols of BMT, bone marrow transplant, hematopoietic, autologous hematopoietic stem cell transplant, has been changed, and they are becoming more and more usable without so severe immunosuppression at the beginning. So it's actually usable. We have for highly evolving at least 1 or 2 patients a year who get BMT as 4th line. But for whoever asked the question, just let me say that the important thing is to be properly stratified and do not delay the intervention with the appropriate treatment. It's not like if the patient is highly active right now, just wait and treat with a better medication. In 2 years, giving a chance for a milder medication, just betting. It's like poker. You see, it's betting on the wrong time, because you might lose 2 or 3 years of appropriate control. So the important thing is really stratifying, really making sure the patient is highly active and treating from the beginning.
Okay, thank you. There is a question by Pierre. How can we stay aware and updated in case you are interested to be in clinical trials? He completed cladribine. Now it depends, Dr. Ayubi, if you would like to answer it, please, because it's reference to Lebanon.
Yeah, it's easy just in being in contact with the primary physician. So the neurologist where the patient is following up, Pierre, or is going to basically be informing where are the centers that are having clinical trials. In Lebanon, we have the disadvantage that we are a small country. We have few academic centers. We all know each other. We all collaborate, and we all communicate between among neurologists, and we get referrals and counter referrals. We collaborate with our colleagues in another centers who have less exposure to MS, and we keep helping, and we always have this communication. So it's easy for them to know if which center has any new clinical trial ongoing. Also through the website, they can get to know when we are recruiting for new clinical trials. Let me say that over the past 4 years, many clinical trials were shy away from Lebanon because of the situation, but now they are coming back. We are having a lot of investigator-initiated trials from PIs in Lebanon and pharma companies as well. So just communicate with the physician.
Okay, there is
Dr.
another...
Ayubi, I think we
sorry.
should collaborate offline. We should talk about collaborations offline potentially.
Let's do so.
With pleasure.
Okay, there is a question by Mr. Muhammad. Should treatment be switched if there is no relapses, knowing that MRI slow MS disease activity? Show MS disease activity.
Sorry, Vicky.
Should treatment be switched if there are no relapses, knowing that MRI show MS activity?
Yes, that's I think Serge also agrees. This was the old school where we just wait and see. The patient is doing well, having 1 or 2 or 3 lesions per year. That's okay, letting them accumulate and then paying later. This should not be. The patient, this means just, let's say, what it means is that the treatment is not being able to control the immunity from attacking the myelin. Even if the patient is not feeling anything, it just means that the immunity is still attacking. And if the patient is not feeling anything, it's not because the attack is mild. It's because their body is strong and able to remyelinate and bypassing this conduction block. And that's why the patient is not feeling symptoms. And that's not a good aspect. That's why patients have to continue their monitoring with the MRI and the clinical exam and all of this, and definitely should change. Whatever the treatment is taking is not working.
I agree as well. And I think, but there's also the one caveat is the balance of increased therapy side effects with the progression. Definitely radiological progression is now considered a sort of a separate risk factor for patients progressing. For patients having worse outcomes in the future. So it's important to sort of balance that against the benefit of treatment and the risk of side effects and look into there. But yes, that's why imaging is still part of a staple of the management that needs to continue to be happening.
Okay. There is a question by Ryan. Is Tysabri as effective as rituximab? Is it considered an aggressive treatment?
So, do you want me to go, Serge?
Yeah, I don't mind.
That's an interesting question that has been answered in a couple of real-world studies, MS-based, and we are in the MS-based as well. And we had this recently accepted paper with Dr. Yammout and Dr. Zainuddin, comparing in a propensity score match the rituximab and natalizumab, and actually they are very, very similar. They are very different in the mechanism they work, but as for control of disease activity, you can consider that they are similar. Of course, what patients should be, Ryan or whoever asked, what they should know is that they should not compare the medications by the number as like a relative efficacy. They are not compared in clinical trials head to head. And they should leave this decision to the physician, the specialist who will have the appropriate personalized approach according to the potential risk factors, the side effects, the potential risk of immunosuppression, the need to control the disease, all of this. So, but yes, we can say both work for, and Dr. Serge showed that both are high in the category of for highly active or for high efficacy medications.
Yeah.
And she's asking also, is ocrelizumab known to cause same immune suppression as rituximab?
Yeah,
Yes.
they work on the same cell. They work on the same cell, a bit fashionable, less side effects on the immediate. The complement-mediated thing is different, the way they kill B cells, but should not be very worried about the word immunosuppression on the immediate term if there is highly active MS. I mean, this is something on the long term. And by the way, Serge, we do a lot of research and extension interval dosing. And recently we also had this with Dr. Khouri, some publication. We'll show it also in ACTRIMS about the extended interval dosing. We really think that we can mitigate the effect of immunosuppression. We are worried about immunosuppression. We are worried about hypogammaglobulinemia on the long term, but we really think there is a role in controlling the disease early on. So Ryan should not be very worried if she's being followed up with a specialist. It should be okay.
Okay, so not to drag a lot, we don't have lots of time. Does environment impact the incidence of MS? This is a question by Ibtisam.
Yes. So there is a correlation between the level of pollution and all-cause mortality and all neurological disease, but there was a subgroup for MS specifically, and this was last year looked at in the neurology journal as well. Otherwise, I guess if we look at environment in terms of exercise, nutrition, all of that, this is also very important as well. So in MS, actually consuming lipids is important. There is a sort of a controversy there on whether or not statins can help decrease neuroinflammation, not as a primary effect, but as a secondary effect. But if we look at environment, living in a situation where there's access to clean water, less air pollution and sort of other types of pollution, access to good quality food is always very important. So in some ways, this might be important to support our rural patients or the patients living in far areas, as far as areas are in Lebanon, to be able to, because they have the benefit of being able to access foods with potentially safer situation, as well as to avoid the pollution that happens in Beirut, specifically in bigger cities.
Mm-hmm.
So yes.
Thank you, Dr. Ayoubi. Thank you, Dr. Jara. Please, those who did not answer the poll survey, please do. You have the questions on your screen. As a closing remarks, I thank you all for joining us today for this vital discussion on MS, access to treatment and real-world clinical perspective. We'd had the opportunity to explore recent therapeutic advancements and shed light on the pressing challenges faced by MS patients, particularly here in Lebanon, from the evolving landscape of treatments options to the systematic barriers impacting today's sessions reaffirmed the need of multi-stakeholders collaborations. Thanks to you, clinicians, healthcare workers, whom I send them our regards, private and public sectors, NGOs, support groups to ensure no MS patients is left behind. As we move forward, let us remain committed to translating scientific progress into equitable care together. Through advocacy, innovation, compassion, research, we can work toward a future where every patient living with MS receives timely, effective, and affordable treatment, an aim we at Lebanon we long for. Once again, I thank you on behalf of everyone for your participation, your insights, and your continued dedication to improving the lives of those affected by multiple sclerosis. Have a joyful evening. Thank you, everyone.
Thank you so much.
Thank you, Vicky. Thank you, everyone.